I'll follow on from where June left off and skip over some of the areas that would be duplication of what June talked about, and look at Parkinson's disease in older people. My clientele tends to be the very old people, 80 and above, and we see quite a lot of disability. So that sometimes biases the way which we look at this cohort of patients. But I'll take you through some of my and share with you some of the situations that we encounter. Just a few things. I'm not going to be able to cover comprehensively. Similarly, with younger people, one of the biggest dilemmas is making the right diagnosis, and I'll talk a little bit about that. And then I'll speak a little bit about 2 or 3 areas specific to older people, the motor problems, particularly some of the problems with dyskinesias and falls and postural hypotension. And we'll maybe take a little bit of time to explore the non-motor problems, particularly behavior, nutrition, and the bowels. And then speak a little bit about rehabilitation and support. Why are older people different? I think partly because multiple comorbidities are more common. You may have extrapyramidal symptoms for many other reasons other than Parkinson's disease, including medication and including psychiatric drugs. And vascular Parkinsonism due to multiple cerebral infarcts is also more common. There's cognitive impairment, so history taking and verification of what happened in the preceding weeks may be much more difficult. And treatment is more challenging because your therapeutic window might be more narrow, and the side effects may be more prevalent due to the difference in pharmacokinetics. And they're also on many drugs, and therefore there are lots of potential for drug interactions. And functional decline in an older person with multiple comorbidities can have tremendous implications. Loss of function, including falls, will lead to loss of independence, and this leads to a lot of social issues, which we'll speak about later on. So accurate assessment is important, and the diagnostic criteria has been laid out by June, and also it's in the clinical practice guidelines. And monitoring the response to treatment is key, because if they respond nicely to treatment and the symptoms abate, then you're pretty secure with your initial diagnosis of Parkinson's. But in the population surveys, even in very good hands in expert centers, the clinical diagnosis is far from 100% secure, and you could get up to 20 to 30% inaccuracies when reassessed by independent parties, or when looking back at some of the initial diagnoses later on in the patient's life course. So this is a standard list that you'll see on any PD textbook. But the pitfalls is that in an older person, depression, arthritis, advancing age would also confound things for them. My latest error in diagnosis was a lady that was admitted to the ward for slowness by A&E, and A&E said, admit to geriatrics, query advanced Parkinsonism. And of course, we are biased by what we read, and my house officer phoned me and said, can I start Madopa? I'm sure this is Parkinson's disease. And so I start the patient on medication, and I went up to see the patient and proceeded to demonstrate how slowness and bradykinesia was so important in Parkinson's disease, until of course that same evening the TSH came back to be 75. The patient came back to my clinic yesterday. The TSH is still 50. She's only on 25 micrograms of thyroxine, and she's walking around. A lot of the features that I was so convinced about bradykinesia has since disappeared. So rigidity, tremor, we've spoken about postural instability, we've run through, but I'd also like to take you through the Hon and Ya staging, which is one of the different categorizations of Parkinson's severity. This is very old. It's been around since the late 60s, and it's in the CPG partly because it sort of gives you an idea where the prognostic journey of a patient is in, and it gives you an idea of the spectrum of severity. In the beginning, it tends to be unilateral, subsequently becomes bilateral. Balance is still really not really involved. Then balance begins to be involved, and then when it's fully developed, it becomes disabling and eventually confined to bed. And I think in the practice of a geriatric service, we see a lot of patients with Honan-Ya stage 3, 4, and 5. I'm going to skip these, which June has shown you. So at the end of the day, making a diagnosis of Parkinson's disease is one of clinical judgment. It could be problematic. Common misdiagnoses are listed as above, and the other common, because it's a clinical diagnosis, we don't often scan these patients. But sometimes when they don't respond to levodopa, I think it's important to ask the question whether it could be another diagnosis. And the other mistake which I recently made, there was a delay because I thought initially we could just treat the patient and just see, but subsequently we scanned her and the patient had normal pressure hydrocephalus, and that certainly swings our diagnosis and our thinking. And this is another classical scenario. After about 6 months of medication, the patient isn't responding. We have stepped up the medication appropriately, and again the patient is not responding much. The patient says, I think there's some improvement, but if you look at the gait objectively, it really hasn't improved. The patient's getting more magnetic. I think those are red herrings according to that list that June shared with us. That should alert us. This patient needs a scan. This patient needs a referral to a neurologist or to the hospital. Okay, so the diagnostic pointers, levodopa responsiveness, and all the other things, which it's in the CPG at the back of the book. In a clinic setting, if you look at any PD book, we debated about putting one of these lists in, but thought that we wouldn't put it in the CPG because it's quite restrictive and idealistic. But I think a few things are useful. If you have a long-standing patient with PD who comes back to you intermittently between going into an acute hospital, the weight, if they're on several medicines, then I think that's useful, a supine and standing blood pressure and a pulse rate. Reviewing the clinical diagnostic criteria, have a mental note that there could be cognitive dysfunction. There are issues of mood, which I'll talk about, and activities of daily living, which I'll also talk about. But at the end of the day, if you want to see how well a patient is progressing, a get up and go test, which is basically asking the patient to stand up of a chair, walk towards the door, and come back to the chair, gives you a lot of information. If they can get up without holding on to the arms of the chair, walk to the door, turn around and walk back and sit down without any effort, you know that this patient's probably okay. But if they're struggling, then you know they're progressing on the Honan-Ya stage, and there is a greater severity of PD that you're talking about. The time walk is what we do, the physios do, and that's really unrealistic to do in a GP setting. Okay, so let's turn our attention to just 2 or 3 areas peculiar to older people. Waylock will talk a little bit more about medication management, so I'll move away too much from that. But this is a syndrome that begins a couple of years after treatment with levodopa, usually about 5. And that's when you begin to find problems with excessive movements, which is not related to the Parkinson's disease. In Parkinson's, it's the paucity of movement, the rigidity, and the bradykinesia. But when you start having dyskinesis, excessive movements, and sinew movements, and the patient is on levodopa and lots of other things besides, then you've got to start thinking, is this levodopa related? Is there a problem at the peak of dose? And are there fluctuations which require us to rethink the medication? And so there are numerous strategies which Winglock will talk about later, and that's when it's helpful to review, because at this point these actions can begin to affect a person's mobility. So that brings me to a little bit of the postural, the motor problems, which are useful to think about. Like June said, they tend not to have motor problems and postural and mobility problems in the beginning. They tend to be all right, even though they're a bit slow. But when it becomes a bit more severe, and when there are problems with end-of-dose deterioration, and when there's a beginning of freezing, then you begin to find that function and mobility and independence, and all the problems with it, like falling, begins to be a problem. just to think a little bit about falls in PD. It's like we said, it's not usual to find it as a presenting feature. So if somebody presents with falls, you've got to say, hey, maybe it's not Parkinson's disease. However, when they progress with their disease and they become more advanced, having had a fall is usually a predictor for a person having a future fall. So, in up to 40%, once they fall, it will probably occur again, and up to 90% of Parkinson's disease, these patients will eventually become fallers. Although, of course, if they become Hoehn-Yahr stage 4 and 5, then the rate of falls begin to go down because they become much more dependent and in need of support. As the function deteriorates, most of the falls will begin to happen indoors. And obviously, if the PD duration is longer and the person's older, there is more likelihood of the person falling. Several features. When your foot is so close to the ground in your walking, then your ability to clear obstacles and to trip over things is impaired, and it increases the risk of tripping. But of course, when you're old, you could also have lots of other reasons for falling, and you could fall because your eyesight's not very good, your vestibular function isn't very balanced, you've got peripheral neuropathy from diabetes, your muscles are weak, and in addition to that, your cognitive function is also impaired. So in early stages of Parkinson's, in stage Hoehn-Yahr 1, you don't need to do very much. Hoehn-Yahr stage 2, really, that's when you need to say maintenance of mobility is important, exercise and gait training. And if any of you have had patients that have been to our Parkinson's disease Society talks, the physios run through a number of routines on how to maintain mobility. A lot of the stretching routines, a lot of the balance routines, Tai Chi and Parkinsonism, those are all useful strategies to maintain mobility and balance. The second thing that is very worrying in patients with more advanced Parkinson's disease is that when they are acutely ill in a hospital, two dangerous things happen. When you become acutely ill, doctors are very good at taking off all the drugs. And so if somebody is on Madopa 5 times a day, on ropinirole, on selegiline, and you come into hospital, everything gets taken off. It's disastrous for somebody who requires dopamine for their mobility. And secondly, the other very good thing that we do in hospital, it's to make patients completely rest in bed. So when we see our IB patients, by the time they do that for 1 week, you require 3 weeks to get them back on their feet. By the time they do that for 1 month, it's 3 months before you really successfully get them going if somebody is frail and deconditioned. So mobility is very crucial because if it's not maintained, it can only get worse. So there's a lot of emphasis on rehabilitation, a lot of emphasis on falls, and as your independence becomes more impaired and your judgment becomes more impaired, then a lot of the strategies come towards falls prevention, looking at the home environment, looking at where the furniture is, looking at the bed height, looking at grab bars in suitable places, and all those sensible things about not having things on casters near the patient's bed and so on. And that's when you can begin talking about osteoporosis and also hip protectors and so on and so forth. Related to this problem with mobility is it's the involvement of the autonomic nervous system in more advanced Parkinson's disease. These are some of the definitions, and usually it's associated with other forms of autonomic dysfunction. But in essence, you're looking for symptomatic postural hypotension. If somebody's BP drops from 150 to 130 and they're not symptomatic, you're not really bothered. If the BP goes from 100 systolic to 70 systolic when they stand in the giddy, that's obviously something that to be worried about. But all these specific signs of autonomic function, they're very difficult to elicit in a standard clinical examination. So talking to the patient, especially if they've been if they have PD for a number of years, is particularly useful.